accreditation board for hospitals and healthcare providers. It's a body which certifies the hospital for quality of treatment provided to the patient. Part Hospital is the first in the Saurashtra and Kutch who got NABH accreditation. Mr. Ravi Hirwani will highlight the difference with themselves and the patient also they feel after the NABH accreditation. As now the PHC and CHCs are also getting NABH accreditation, so we need to understand the basic, the needs of the NABH accreditation. Mr. Ravi Hirwani.
Most of the sessions have been completed. You heard Gandhian philosophy, morning, technology and finance. I think quality always takes a backseat. So welcome to Quality Journey.
Though it makes a driving seat for success.
I'm not a quality expert, but I would like to show a small glimpse what we have done and why these have been important. To start with a famous saying by American Medical Association. Quality is the degree to which the care services influence the probability of optimal patient outcomes. So your process, your approach, how you derive it to reach those outcomes. Every organization should have a standard quality agenda for its own organization. It could lead to patient friendliness, care with class, infection control, medical outcomes, a number. It depends on the organization. What kind of quality agenda one has to have for the own organization. As far as the medical education is concerned today in India, we teach a lot of subjects, anatomy, physiology, surgery, medicine, but they don't teach documentation, finances, customer services and important quality. So how to deal with quality? Quality is not always the chief concern when a hospital also is built, because the doctor himself has too many priorities. Being an entrepreneur, being a clinical manager, being a doctor, he has a lot of how can he shift his practice? How can he do more number of procedures? How can he add more value for his services? But where does the quality initiatives, what kind of measures he should take for improving the quality are taken a little back. A few data which we will try to just go through it in a quick brief. This is adverse events in healthcare. And these are the WHO published data. It shows that 10% of hospital patients suffer an adverse event in developed countries also. We are still far. Medication errors. The line itself defines which is leading cause of injury in developing and developed countries. And almost 1.5 million are found and thousands are killed in USA per year. These are small indicators but having a lot of meanings. Other areas like unsafe surgery, wrong site, wrong organ, wrong procedures cost a huge. Injection safety, clinical handovers, again communication. Communication when patient is handled between units in healthcare teams, hospital facility, 15% handover results in adverse events. This is Australia data. And there are many more challenges in unsafe care. And this brings the foundation of quality, whether it is clinical, non-clinical, whether it is organizational, patient-centric, whatever, that becomes important. What is the impact economically? USA has an annual impact of more than 60 billion. These are data published. And healthcare associate infection also have a huge cost to the economy and the European countries too. These are numbers but have a great impact. In Indian scenario, if I talk, why safety? Quality brings safety. Events like Ambry Hospital in Kolkata, where more than 90 patients died. There was a hospital in Punjab, Patiala, where incubator deaths just because of faulty incubators. And then there was a hospital in East, where disaster entirely affected the hospital. So where are we ready if such kind of events or activities we come across? All inclusive, your steps, your processes define everything. As far as Indian healthcare is concerned, only 6 to 7% of hospitals are more than 100 beds. So more than 80% are having less than 30 beds. And 70-80% are in the private sector. So equally becomes important to have a proper accredited standards which govern the uniformity of the healthcare. And it becomes equally important, and I'm wanting to stress that today opening a hospital and opening a pawn shop is same. It's not telling that because the accreditation standards have now come. This much of size, this much of infrastructure, this much of technology, this much of training is equally important. But on the days, it was very easy to open a hospital. There has to be aims of safe healthcare. Safe means avoiding injuries to the patient, patient safety, effectiveness, patient-centered. The hospital's aims have to be patient-centric also, and timely, reducing the waste, efficiency and equitability of uniform care. Just a small brief, people may know about NABH, but just for them it will be an overlapping. NABH stands today in the Indian healthcare as a mark of excellence or the quality, and so some hospitals have already received JCI and Australian accreditation, but today most of the hospitals in India have this mark of excellence as NABH. NABH was constituted by Quality Council of India, and it has linkages with ISQA, which is International Society for Quality in Healthcare, and Asian Society for Quality in Healthcare. These are the two international members which have accredited this NABH body under the Ministry of Health and Family Welfare, which is governed by Quality Council of India, and the Prime Minister is chairman of the council. The history, if I say, we started the references from Ministry of Health and Family Welfare, and technical committee was constituted in June 2005, and then the process followed. So February 2006, the NABH standards, the first edition was launched, which has huge number of documentation, processes, and then second edition came, and 12-16 today we practice third edition of NABH. And Mills Calicut was the first hospital multi-speciality in 2006 to receive the accredited of NABH. Today in India, the applications have reached to 628 as per the 2012 data. It started from minimum number of 29 in 2006. And accredited hospitals today stand around 115 in the country. As a structure of NABH, there is a Quality Council of India which governs the entire norm, under which the NABH performs, and they have different committees like a panel of assessors and experts. They have a secretariat and appeals committee. So accreditation committee holds the final decision of giving an accreditation, and if there are anything which are having conflicts, so appeals committee is an independent body where the appeals could be made in cases of any grievances. There are 10 chapters in NABH to follow, which are just to say 10 chapters, but having 104 standards. When I say standards, expert statements describing the quality and objective elements having a measurable component of the standards. And these are the 10 chapters which one has to. There are patient-centric chapters and there are organization-centric. Access, assessment and connectivity, where you talk about your inpatient services, assessment, when the patient comes to hospital, how well defined your IP and OP processes, whether the admission and discharge are well laid or not, whether your radiology safety programs, your quality assurance programs for lab services are there or not. Care of patient deals with a lot of care inside the hospital, nursing care, your ICU care, your HDU care, management of medication, your safety processes for pharmacy, usage of your drugs, your chemotherapeutic usage, your narcotic drugs, your patient guide and education, hospital infection control. So such kind of, there are different chapters which deals with different kind of quality. And accreditation, definitely everybody knows about it, nothing to say new about it, but it's based on written and published standards. And there are different steps for an accreditation where you start from an application and then pre-assessment happens, final assessment, review, and then verification and surveillance goes on. Today, accreditation stands for allopathic clinics, Ayush hospitals, blood banks, dental facilities, medical imaging services, OST, the oral substitution therapies for narco centers, PHC, small healthcare organizations and wellness centers. Why the accreditation is required? As far as Consumer Protection Act or Clinical Establishment Act, it definitely gives an edge for making process more efficient and effective. And definitely it gives an edge while certain businesses are concerned from insurance and other public sector organizations. And overall health tourism is taking place, which gives an edge from the other competitions. In Gujarat, we have today 6 in Ahmedabad, Baroda, 4, Surat 2 hospitals, Gandhinagar 1, Bhavnagar 1 and Rajkot who are NABH accredited hospitals. I proudly would like to say we were the second hospital in Gujarat. In 2009 we got an NABH accredited, and we are again the second hospital in Gujarat who have been re-accredited after 3 years of accreditation. So these are the numbers who have gone as per the 2009-2013 the accreditation numbers, and these are the hospitals which have received in Gujarat. As far as our quality journey has been concerned, we are having the first tertiary care hospital, definitely different kinds of facilities. We had a consensus to start the NABH and accreditation program, and gap analysis was done, closures of the gap, and the application was done. So 14 August 2008 our journey started. We had a self-assessment by our team, and 2008 the pre-assessment audit in 2009 was finished. Final audit came in May 2009, and accreditation status was granted by June 2009 to us. And again followed by surveillance and reassessment verification, and again in February 2013, just this last month, we have been reaccredited. So as a quality initiative of our own organization, we do a lot of things, like we have self-managed teams which we say SMT, which have different components and people involved in them. Then we have NLP programs, which are nursing leadership programs. We have TTT, which is train the trainer program. We have CQI programs for clinical and managerial indicators. Committees which have different purposes and objectives have been constituted with the stakeholders of those committee members. And we believe in 3M concept, which says the patient is the most important as far as the men, material and method is concerned. So we have equal eyes on all these points of consensus. And on the clinical side, we have we follow statutory compliances. There are enough kind of statutory compliances, are very complex statutory compliances as we are going ahead. Internal audits we keep on doing. On the clinical side, we do FSA 4, which is, for example, for the ICUs, Euroscore for cardiac surgeries, door to balloon time, AMI, that is acute myocardial infarction, and HAF audit 2, medical records audit. Then we have defined ICU admission criteria, that this person has to be in ICU or he has to be out of ICU. Similarly, we have rapid response teams who say the patient in ward, if he has score of say X or Y numbers, he has to be in ICU or he has to be in wards. VAP bundle and UTI bundle introduction, structured medical officer training is a continuous program, and setting audiovisual conferencing facilities for intra-group communication across our hospital locations. There are 64 indicators which are mandatory, we have to follow, we have to document it and keep on saying, and mandatory indicators are submitted on quarterly, which are general, clinical and managerial. These are some of the mandatory data which we have to send to NABH on a quarterly basis, and these have to be monitored on a monthly and fortnightly basis. Just to present ourselves in total transparent manner, time for our initial assessment for emergency patients is 3 minutes 82 seconds. As far as the patient arrives in the emergency, we initially assess the patient. Percentage of report correlating with clinical diagnosis is more than 92%. As an average, you can see it's more than 92%. Our average length of stay is, as a comprehensive overall, is 3, less than 3.5 as an average length of stay, and our patient satisfaction index is more than 80%. Waiting time analysis, supposed to we keep on monitoring all these. Its average across the hospital is 19 minutes, and time taken for discharge is 64 minutes. Respiratory infection rate we have brought down in December in 0, but yes, because of the nature of the care what we have in the sick patients, we have 4 to 5% always as a numbers for respiratory in the percentage term. And as far as bloodstream infection rates are concerned, there is a small percentage hike in that. It's but less than 2%. Aortic injuries, yes, there is a slight high, which shows that in that month we analyzed it. It was a new staff who have been trained, but these are like discarding when we do the stick injuries happen. Not at the patient, we have almost an occupancy of 75%, just 5 to 6 kind of little stick injuries have been reported. And total time taken for door to balloon is 1 hour 6 minutes. Means from patient we receive a cardiac patient in ER and the balloon is inserted, it's 1 hour 6 minutes. This is a beautiful study that we did just a few days back. It shows our Apache scoring where predicted mortality was 5.86 with the scoring between 0 to 50, but our actual was 0. And between 51 to 100 it was 27 and actual mortality was 24. So we probably showcase this data, we definitely not put it in papers also. Quickly, just to summarize, what are the benefits as a healthcare organization? It gives an opportunity to benchmark the best, definitely to us, and it gives us business privileges with institutional clients. And patient customers, definitely the rights of patients, customers are respected, protected, and it gives high quality and customer satisfaction. As to staff, they are lot satisfied, they are in a safe environment, and improves the professional development of them also. The benefit to the process is that it becomes more and more evidence-based. And challenges were two main as far as product practices are concerned. It was a lot of challenges for us initially to get good manpower. We have to train a lot of manpower. So those kind of extra work, express of documentation, and the philosophy and the cost concerned to that. And externally, statutory compliances, because a lot of things are new for a lot of people, and dependency on a lot of vendors, Ahmedabad, other Bombay, we have to do geographical and cultural diversity also. So as I would like to say the same thing, quality is a journey and not a destination. And definitely NABH has given us a proud accreditation, has given us certain meaning of providing safe patient care, a proper care pathway, and better infrastructure management by going for this. And believe me, definitely it adds a value to your overall process. Thank you. Thank you.
Thank you, Mr. Ravi Hirwani, for sharing success story of Vokha with NABH, which really shows that NABH is not only about documentation, but is actually helping patients and hospitals as well. Now, Dr. Meena Supal is present women to Thank you, Meena.